with nausea, so I don't know which one it is. But even then, that's not that terribly confusing. You can do the experiment where you temporarily hold one and see what happens to their symptoms, and then temporarily hold the other one and see what happens to their symptoms. So again, to me, you can figure it out even if the side effect profile are similar between the two drugs you're using, you can still figure out which one is the culprit. So that argument has never really made a whole lot of sense to me. The other one is about concern about giving unnecessary medication to a patient. Now, that one, again, I don't fully get, because the reason you would use combination therapy is because you felt that that person would benefit from both therapies at the same time. So in the case of, and the reasons for that might be glycemic, or it might be outcome reduction plus glycemia. So in the case of glycemic, well, I'm going to offer initial combination therapy if the A1C is high enough to a point where I felt like one drug was not going to be enough. So why waste time and use one drug when I could use both? Now, let's say the person also incorporates fantastic lifestyle modifications at the same time, and their next A1C comes back at 5.5%. Okay, well, at that point, if it was purely for glycemic reasons I was using the two drugs, I could always pull back one component, in which case the patient's happy. So again, I don't really see it being unnecessary medication as long as I'm giving things that are not causing hypoglycemia. Now, if I'm using combination therapy, though, to offer outcome reducing therapy and provide glycemic improvement, well, then I still need both because I'm giving them for different reasons. So again, it doesn't quite make sense to me about this concern about unnecessary medication. And then the concern that the patient will not accept two medications at once, well, that's up to us to explain it. It's up to us to explain to them why we're thinking about this. But then I always tell them, you get the benefit of both in one pill or one injection, whatever the case may be. And for many patients, that's actually acceptable because it's one name on the box, it's one name on the bottle, it's one name on the prescription. So their minds are still taking one medication, but then they're getting the benefits of two things. It's a 2-for-1. It's like a sale. It's a 2-for-1 kind of situation. And that I find often helps patients wrap their heads around that. And especially if we want to give them the benefits of both of these things that we're aiming for when we're trying to help our patients living with type 2 diabetes. And we want to use therapies with proven benefit, as have been shown in this table. But at the same time, we still need to give them the glycemic control. And these are the patients where we know we should be offering them the SGLT2 inhibitor and or the GLP-1 receptor agonist. But at the same time, we want to achieve glycemic control. And that's where the metformin plus combos make a lot of sense, so that we can give them the benefit plus give them some further A1C reduction. And you guys have already seen this algorithm from myself of the way I like to think about approaching type 2 diabetes is giving them the best of both worlds, giving them the outcome reduction, but also giving them the glycemic benefits of metformin and the reductions in insulin resistance. But the other combination that I think also makes sense, and you'll hear more about later, is if we want to give an SGLT2 inhibitor for outcome reduction, but in a patient with reduced renal function, we know that they're not going to get the same glycemic efficacy in that situation. So then that's where adding something else that would give them glycemic efficacy, even at the lower GFRs, is beneficial. So the SGLT2 piece is giving them the renal and CV protection, and the DPP4 component is giving them the A1C reduction. You could do that with the GLP-1, of course, but then now we're talking two separate medications. So that combination of a DPP4 SGLT2 does make a lot of sense, particularly in that renal kind of patient. So to summarize, hyperglycemia is multifactorial. So we need a multifactorial approach to try to address hyperglycemia in our patients. Combination therapies allow us to better achieve the two things we're trying to achieve, outcome reduction and achieving glycemic targets at the same time. The side effect profiles are distinct, so we can figure it out. And in my mind, why waste time? Like, if you know someone's going to need more than one therapy to get where they need to get, then let's give it to them. But let's give it to them in a way that will help improve adherence, which is usually in the form of a combination. So with that, I thank you for your attention, and I'll stop sharing and we can pass on to the next speaker.
Thank you very much, Alice, for a wonderful presentation as usual. I think you have paved the way for perhaps the rationale for using more combination therapy as we go across in our clinical practice. I guess you're using it in your clinical practice whenever you can. So you're talking out of experience, out of preference as well. And I think now it's probably, you have shared a lot of combination therapies available in the market with different combinations from different classes. But I think one important combination that has been introduced in the markets recently is a combination between DPP-4 inhibitor and SGLT2, one of the most prescribed classes after metformin nowadays over the past few years. And I think the combination of those two medications on top of a free metformin may be also an additive benefit for management of type 2 diabetes from many aspects. And I think we will hear a lot about it from Professor Mike. So let me pass the floor for him, and we hope to hear from him everything about it. Thank you.
Well, good afternoon, everybody. I'm very pleased to be here. I'm just going to bring up my screen.
Yes.
Good. Hopefully that now gives you a full screen. So I'm very pleased to be here again for the fourth session. Really enjoyed the previous three sessions and our discussions subsequently. You've heard a very elegant discussion from Alice, describing why combination therapy may be appropriate and a good thing, and the potential benefits of doing that. What I want to do now is drill down on a particular combination, that is DPP-4 inhibitor and an SGLT2 inhibitor. We've heard a lot around the use of linagliptin and empagliflozin. So I, within this example, will focus upon these particular two agents. Now, in your countries, you may have a fixed dose combination of these, you may not, but the value of these two combined together, I hope will become even more evident as we go through this talk. So there are my disclosures again. So really to add to the comments we've heard from Alice, obtaining good glycemic control, we all know is a major challenge. And if you look at this slide on the left, you can see here the likelihood at any one time of optimizing glycemic control in all our patients is minimal. So the minority, you can see here, roughly a third of individuals obtained an HbA1c below 7%. The majority typically have an HbA1c above that target. And of course, if we know if we're using one therapy, that the ability of that agent to obtain optimal glycemic control declines with time. So on the right here, you can see that as the time moves on from 3 to 6 to 9 years, the use of metformin, for example, to maintain an HbA1c below 7% clearly deteriorates. And by 9 years, only 13% of individuals, an absolute minority, obtain good glycemic control. Now, although we know intensifying glycemic control is the right thing to do, Alice covered very well the fact that there is this clinical inertia, and that we tend to rate a long period of time before we add a second therapy. And this therefore gains credence to the argument that combining therapy, for instance, with two agents at once, with or without within a fixed dose combination, may help to improve things. And you can see here on the right here that if you have an HbA1c above 8%, it takes over 1.5 years on average before it's likely there is intensification of therapy that could have been done right at the beginning. And as you get closer to HbA1c, our temptation is to leave it even longer. And you can see that you're approaching nearly 3 years if your HbA1c is somewhere between 7 and 7.5% before the therapy is actually intensified. So many of us have been in the habit of, through intensification, actually just increasing the dose of the current glucose therapy that the patient may be on, rather than adding another glucose lowering therapy. And this slide, as an example with metformin, shows why that isn't a terribly effective approach. So you can see with metformin as an example that as you intensify therapy, for instance, the majority of dosing effects is achieved by 2 grams of therapy, but you increase it above that, you're not really seeing any improvement in HbA1c. Most of the effects occur with the early initial dosing. And of course, on the right here, not only will you see that there is no particular gain in HbA1c drop, but the likelihood of side effects, and with metformin, gastrointestinal side effects increases. So monotherapy, increasing the doses, isn't a particularly effective strategy at optimizing glycemic control. So Alice showed this slide, the fact that we recognize type 2 diabetes is much more complex than we initially thought. It's much more than just insulin resistance and insulin deficiency. This is the so-called ominous octet, showing all these different abnormalities we associate with type 2 diabetes. And of course, therefore, give us an option to develop newer glucose-lowering therapies, but an option to utilize some of the agents that we already have in fixed dose combination that will tackle a number of these different abnormalities associated with the pathogenesis of type 2 diabetes. So targeting these multiple pathways is a much more effective strategy to optimize and improve glycemic control with minimizing side effects, rather than just flogging a given dose up to the maximum dose and hoping that will be sufficient. That doesn't work. So we already have had many examples in the past of combination therapy that improve glycemic control beyond just using monotherapy. So here you can see studies that have looked at fixed dose combinations. If you compare with metformin in the grey, here linagliptin in the purple, combination therapy offers a much more effective drop in HbA1c. And on the right, the use of combined empagliflozin and metformin, a far more efficacious drop in HbA1c compared with either empagliflozin or metformin individually. So the advantages of combination therapy, and building on the comments from Alice, are firstly, we're likely to see easier achievement of glycemic controls. Secondly, perhaps different to what you might expect, there's the potential for a reduction in dose-related adverse events, because we're not necessarily using the higher doses of therapies, which may not offer significantly improved glycemic control and open up the likelihood of more side effects. We know that intensifying glycemic control earlier, for the reasons Alice mentioned around the so-called legacy effect, less years with poor glycemic control, has the potential to delay disease progression. And this opportunity to combine therapies with complementary modes of action is very attractive. So what I would like to do when we're specifically talking about empagliflozin and linagliptin is recap the potential benefits of each of those therapies. So briefly, when it comes to empagliflozin, first, if we think about its ability to drop HbA1c, it's been rigorously tested in a number of different studies, either as monotherapy or as dual therapy with metformin, or with combination and triple therapy, combination with insulin, and mild renal insufficiency. And whichever of these studies you look at, you see an effective reduction in HbA1c and consistent reduction. So this drug does what we expect it to do. It reduces circulating glycemia. But on top of that, and what appears to be independent to its glucose lowering effects, we see that it has this ability to reduce cardiovascular events. Again, the EMPA-REG outcome trial showed this early, within a few months, significant 38% reduction in cardiovascular deaths, concomitant reduction in heart failure, and cardiovascular, not only cardiovascular, but overall mortality, on top of standard care. And it doesn't matter what the baseline picture is for the patients in the EMPA-REG outcome trial. So regardless of whether they'd had a previous atherothrombotic event or not, regardless of whether they had heart failure at baseline, and across the spectrum of cardiovascular and heart failure risk, we see that all these groups benefit from the introduction of empagliflozin. And not surprisingly, therefore, and what we've consistently reinforced through the 4 sessions, is the fact that this study and others have contributed to the fact that we must think about atherosclerotic events right at the onset and risk for our patients. And if they have high risk or have atherosclerotic cardiovascular disease, then this leads to our choice, which often is an SGLT2 inhibitor with proven efficacy in terms of reducing cardiovascular events. But what we know with a natural progression of type 2 diabetes is that glycemic control will continue to deteriorate. That's the natural history. We know that single, even dual therapy is unlikely to result in stabilized glycemic control year after year. And therefore, adding in additional agents early and aggressively, and often in combination, means that we're going to likely to maintain better glycemic control for a much greater period of time and reduce this risk of glucose toxicity and additional hyperglycemic burden. And this is where the use of DPP-4 inhibitors in particular are very effective. And we've heard from Julio Rosenstock the last 3 weeks the benefits of DPP-4 inhibitors, and just to re-emphasize within the current standards of medical care throughout the world, and this is the ADA guidelines, why that is with the DPP-4 inhibitors. Well, they are well tolerated. There's a low risk or no risk of hypoglycemia. They don't promote weight gain like sulfonylureas, the glitazones or insulin. They have a fantastic safety profile, and they're easily adhered to. We know that with linagliptin, it produces a very consistent reduction in HbA1c, and this is shown in line with the other DPP-4 inhibitors. But an HbA1c reduction of 0.75%, and this will be higher. If you start with higher HbA1cs, we know we'll get an even greater reduction with these therapies. We know that the side effects are minimal with these therapies. There are very few patients who have to stop the drug because of side effects. Again, the drug, specifically with linagliptin, it's actually excreted through other routes, through the bile, with very little excreted through the renal tubular mechanism. And this means that in consequence, that although we can use all the DPP-4 inhibitors in individuals with renal impairment, if you use linagliptin, the dose adjustment isn't required. The single dose, 5 milligrams a day, will be suitable for all patients regardless of their renal status. We've also heard from Julio the more recent data on the safety with linagliptin. This is data from the Carolina study looking at cardiovascular outcome, the 3-point MACE, and you can see that these lines superimpose. So there is no increased risk of cardiovascular events occurring with linagliptin in comparison with the sulfonylurea glimepiride. And similarly, if we look at data from the Carmelina study, this was different because it was the only study that really focused heavily upon patients with chronic renal impairment with CKD. So a highly prevalent CKD population, and not surprisingly, a high number also had established cardiovascular disease or both. And we know in that study, you can see here at the bottom, again, cardiovascular safety was very clearly shown. And this was similar finding with all the other DPP-4 inhibitors. But of course, this observation in the Carmelina study for the first time extended this finding to those with significantly impaired renal function. If you look at these DPP-4 inhibitors in terms of heart failure risk, again, you'll see the slight differences here. The Carmelina reinforced safety of no increased risk of hospitalization of heart failure. Statistically, this was similar for the other agents, except with saxagliptin in the Savatimi 53 study, which showed this rather unexpected finding of increased HHF with its use. An intriguing observation, again, within the Carmelina study was breaking this down to patients of Asian descent. Again, very reassuring. There was no increased risk of any cardiovascular events in both in the Carmelina study, and if anything, a slight suggestion of a reduction in heart failure risk with the Asian population here, although numbers are less. So two agents with a number of potential benefits. They work in different ways. So the combination of these two sound very attractive. We want to know that these therapies, if combined, don't interfere. There's no drug interactions. And so firstly, just to show you some of the pharmacodynamic and pharmacokinetic data. And what you're seeing here in these graphs at the bottom is the concentration of empagliflozin on the left and linagliptin in the right. And you can see if you use empagliflozin on its own in the green, after you take it, here's the rise and fall in concentration. But if you combine it with linagliptin, there is no real difference in empagliflozin concentration. So again, reassuring data that there is no interactions between the two on circulating concentrations. And this equally applies to linagliptin. So either linagliptin on its own or in combination with empagliflozin, the mean linagliptin plasma concentration remains the same. So your patient is exposed and receives gets the same circulating concentrations of both in combination. So we've mentioned that this combination attacks the different pathophysiological abnormalities with type 2 diabetes. And actually, it's 5 out of these 8 core defects we associate with the ominous octets that we would seem to be addressing with the combination of these therapies in tackling glycemic control. So what about any definitive studies that have looked at combination of empagliflozin and linagliptin? And this is taken from Ralph DeFronzo's and colleagues' study, which addressed that issue in particular. So just to talk you through this, you'll see on the right, individuals received linagliptin or the 2 doses of empagliflozin, or using a combination of either EMPA-10 or empagliflozin 25 milligrams a day in combination with linagliptin. So that's the background to this study. You can see individuals entering in the study. The main additional point of this study of this slide is to show you that they were well balanced, similar ages between the different group, similar distribution of male, female, of weight, of race as well, and also duration of diabetes. You can see that this was spread, not many people with diabetes less than a year, and we could argue and discuss at the end, actually there may be an argument for making sure that more individuals have their therapies and dual therapies at least introduced very early in combination therapy. And Julio has argued very passionately about this in previous sessions. But you can see here roughly a third had diabetes for 1 to 5 years, the same for 5 to 10 years, and just over a fifth having long-standing diabetes over 10 years. In this study, again, equally matched for HbA1c, somewhere between 7.9 and 8%. These were overweight individuals with a BMI typically between 30 and 32 kilograms per meter squared. They had good blood pressure control, and you can see that the eGFR was well preserved in each of these groups. So what did we see in mean outcome in terms of HbA1c at 24 weeks? So looking from the right and then moving across to the left, you will see that with linagliptin and empagliflozin, you get the typical HbA1c reductions that you might expect with those agents. But as soon as you combine, so that's with either 10 or 25 milligrams of empagliflozin with 5 of linagliptin, you see a much more pronounced reduction in HbA1c. And I rather like this and re-emphasize that this more intensive reduction in HbA1c helps to reduce this glucose toxicity, and in my mind helps to reduce the risk of future glycemia-related complications, but also potentially reducing this glucose toxicity early means that there is a greater likelihood that you're going to not need to intensify glucose lowering therapy so rapidly. So translating this reduction in HbA1c to targets, not surprisingly, in combination, we're going to see a greater number of individuals reduce, achieving that HbA1c target of less than 7%. So here you see approaching 3 out of 5 individuals will achieve it with combination therapy straight away, compared with a much lower number in those individuals going on to one agent alone. And if you start with a higher HbA1c, so here you see an HbA1c above 8.5%, a much more pronounced reduction in HbA1c going on to combination therapy. So here, somewhere between 1.6 and 1.85%, really important and meaningful reductions in HbA1c occurring quite quickly, rather than the drawn out process of adding in one agent to the other. And this combination of therapy is something, because you're tackling different aspects of the core defects associated with type 2 diabetes, we see that this reduction shows good reductions by 6 months, even better reductions by 12 months. And look, by 12 weeks rather, sorry. And look, these reductions are maintained. So in this study over the 52 weeks, we don't see this progressive rise in HbA1c. And if those of you are familiar with the UK PDS study, we know that achieving HbA1c again was achieved over a number of months, but there was this gradual drop off and rise in HbA1c over that subsequent 12 months, which is different to what we see here with combination therapy. We know that linagliptin is weight neutral. We know that empagliflozin results in weight loss. So this is what we see with the individual therapies. Not surprisingly, in combination, we get that combined effect. No surprises here with change in weight. The same with blood pressure. Linagliptin doesn't tend to have much effect on blood pressure. We know that empagliflozin drops systolic blood pressure. This is a valued additional effect. And in combination, guess what? We see this consistent effect on reducing blood pressure. Side effects, again, what this slide shows you is that not many individuals had severe side effects that led to discontinuation of that therapy. And the combination dose here is no different to that you would expect associated with each individual therapy. And those side effects relate to the individual impact of each particular therapy. So there are no surprises here in terms of side effects. They relate to side effects in the fixed dose combination, either of empagliflozin or linagliptin. As we know, they're mild side effects and frequently do not result in having to stop these therapies. We've heard in the last few weeks about special interest side effects. So, for instance, with the SGLT2 inhibitors, urinary tract infection and genital infections, volume depletion, and these other side effects. And as you can see, there are no differences, no surprises with using these agents in combination. They reflect the side effect profile we associate with each individual drug. None of them are cause severe side effects and unexpected findings in either in a single event or in combination. So really reassuring data about, again, around using these agents in combination. So let's think about this in clinical practice. So what I'd like you to think about is Rosie, but I'm sure you've got plenty of Rosies in your individual practices. Rosie is 63. She's had diabetes for some time now, 14 years. She's also hypertensive. So her medication reflects what you might expect. With 1 gram twice a day of metformin, she's on her linagliptin, she's on her statin, and she's also on the angiotensin receptor blocker, irbesartan. You'll see that her BMI is 27 kilograms per meter squared, and she's got good blood pressure control. Her HbA1c is rising. It's now suboptimal, so we know we need to do something about this. It's currently 7.8%. With time, we see this slow decline in eGFR, but still quite good, 78 mils per minute. We can see that our lipid parameters, we should be fairly happy with here. However, she's presented with chest pain that clinically represents angina. She's fearful of injections. And so we need to think about how we're going to manage her in the context of this new presentation. So my thoughts around the management of the case, of course, She presented with chest pain that we think is angina. She needs an ECG and cardiology review. And again, they diagnose angina based on the clinical history and ECG. The angina is related to exercise. They look at medical therapy, having assessed her further with an exercise test, and she is placed on aspirin and bisoprolol. We mentioned that her HbA1c is the metabolic target that stands out as being suboptimal, so we would like to improve upon this. And we have a number of options we can think about. Sulfonylureas, the glitazones, SGLT2 inhibitors, or GLP-1 agonists, or as we've discussed, along with pioglitazone, don't really offer improved glycemic control, but don't offer some of the other benefits. We're likely to see weight gain with both of these agents. We're not keen on glitazones in the aging population of females, increased risk of a reduction in bone density. And of course, we have this hypoglycemia risk. We've heard that Rosie's not keen, as many of our patients are on injectable therapy. So actually combining with an SGLT2 inhibitors makes eminent sense. We're likely to see an improved glycemic control, and we see this adjunctive improvement and reduction in cardiovascular risk. We'll see that she had a baseline BMI of 27, so this affords a further reduction in weight loss, and of course it avoids injections. So the combination therapy makes sense. And again, although this lady has had type 2 diabetes for some years, when SGLT2 inhibitors weren't available, if they were, I think a combination of adding in her SGLT2 inhibitor with the DPP4 inhibitor much sense. So just summarizing, looking at the individual components here, empagliflozin has proven glucose, weight, and blood pressure lowering efficacy, but it also has this proven cardiovascular benefit. Linagliptin, in addition, has this proven glucose lowering benefits and has no adverse effect on weight. And it's got this extensive proven safety record, probably greater than the other DPP4 inhibitors in terms of, and by that I mean it's been more extensively investigated, looking at in 2 larger trials comparing the sulfonylurea and glepaglutide, and also in patients with extensive renal impairment, and is safe. We know that the progressive nature of type 2 diabetes is that combination therapies, combining them, is needed, and therefore it makes eminent sense to do it earlier rather than wait and seeing this progressive decline in glycemic control, which will then have an impact on enhancing vascular risk. So empagliflozin and linagliptin represent, in my mind, this ideal combination to combat many of these metabolic components of this condition and reduce cardiovascular events. So at this point, I will stop sharing my slide and hand back to Mohammed. Thank you for listening.
Thank you, Professor Mike, for a wonderful presentation. I think it was really clear to us that perhaps this combination, new combination, may be an additional solution when we are trying to tailor and manage our patients, and there are compelling, probably clinical situations that maybe this combination may be optimized and used preferentially. Now, I think the last session that will complete the whole picture is what is the guidelines and the consensus has to say about how we can manage patients with cardiorenal risk, and in particularly why cardiorenal risk. If you look in our region, we have an incidence of diabetes that goes on between 15 to 20% in our population prevalence. We have a prevalence of hypertension that goes on within the 30 to 35% of our population, and we have a prevalence of heart failure that goes on from 2 to 4% in our population. And all of this happens also in earlier age compared to our Western population. So if these recommendations that are going to be discussed with us today is addressing the aged population or the patients who have lesser risk, our patients have more risk and probably should be adapting more of those recommendations earlier, and our cardiologists and endocrinologists and internal medicine doctors should probably take action faster to protect our patients. Without further ado, let me leave the floor for Professor Khalil Rosenstock to take us through these recommendations.
Thank you, Mohammed. Can you hear me?
Yes, Professor, we can hear you.
Well, thank you very much, Mohammed, and thank you very much to Boehringer Ingelheim for these 4 sessions that I enjoyed very much, and I hope that all of you have enjoyed from
I think your voice is breaking, Professor Rosenstock.
Chen and comments. There's a lot of things that we have discussed over the 4 sessions, and I'm going to try to summarize and try to get the things in the right. Discussing what are the consensus recommendations for the management of type 2 diabetes in people who have cardiorenal complications. And my attempt is going to provide clinical translation to the treatment guidelines. So this is my disclosure that I've presented before, it hasn't changed. So as we try to go through all these consensus recommendations for the management of type 2 diabetes and cardiorenal complications, translating type 2 diabetes treatment guidelines, let's look first at what Mohammed just mentioned in terms of the increased cardiorenal disease frequency in people with type 2 diabetes. For instance, people with type 2 diabetes have twice the risk of cardiovascular disease compared to the general population. As you all know, it's a 2 to 5-fold increase in risk of developing heart failure. For years, we've been so much focused on atherosclerotic disease and myocardial infarction, but the truth of the matter is this has been the unrecognized serious complication of heart failure. And once you develop heart failure, is a high increased mortality, almost 50% in 5 years. And also kidney disease is estimated to affect up to 40% of people with type 2 diabetes globally. And when you have a chronic kidney disease, the chances of cardiovascular disease increase much greater. We all know that diabetes is associated with an increased prevalence of cardiovascular risk factors. Hypertension, obesity, and dyslipidemia are prevalent, as least in 60 or 70. Increased oxidative stress. You can have some vascular calcification that has a prognostic value, a marker. And chronic kidney disease, as I mentioned before, puts even a much double or triple risk of what is already established in type 2 diabetes. So for instance, when you have type 2 diabetes and chronic kidney disease, the mortality risk goes up 4-fold greater. In this study from the NHANES data from the United States, you can see that comparing the people with previous MI, diabetes, and chronic kidney disease alone, type 2 diabetes, and no diabetes or chronic kidney disease. If we focus on people with type 2 diabetes and chronic kidney disease, you can see that is 4 times increased mortality risk. This is very serious. And when we looked at myocardial infarction, the same is true. It's highly increased. When you have type 2 diabetes and chronic kidney disease, the risk is increased 2.5 times greater. So when we look, for instance, at a patient with type 2 diabetes, age 60, and this is data that has been extrapolated to the very well-established emerging risk factors collaboration study published in JAMA in 2015. If you have somebody with no diabetes or cardiovascular disease, this is the expected life expectancy. Average life expectancy. If you have type 4, this is before the advent of GLP-1s and SGLT2 inhibitors, you will lose 6 years of life. If you have type 2, hopefully, we have better tools now to tackle these numbers. And indeed, we're these days focusing on preventing, on reducing cardiorenal events. That has been the focus in the last 5 years. And the strategy is to reduce cardiovascular risk in type 2 diabetes. The ideal is if we were to prevent type 2 diabetes. And of course, doing that with obesity, lifestyle losing weight, in lifestyle intervention with exercise, and in some high-risk people with metformin. And we now have initial evidence from the DAPA heart failure study that in those people who were enrolled without diabetes, there's a chance that SGLT2 inhibitors may also prevent type 2 diabetes. And we look forward for studies in that area. But prevention type 2 diabetes will be the ideal. Identified and treating type 2 diabetes early is also very important, as Professor Chen, Professor Alice mentioned there. All these years of glucotoxicity that increases the microvascular and probably a component of macrovascular complications. Multifaceted cardiovascular risk factor management, as has been reviewed in this series by Professor Cummings, is very important. And now we have in type 2 diabetes patients a high cardiovascular risk of established atherosclerotic cardiovascular disease, a chronic kidney disease, or heart failure. We have SGLT2 inhibitors or GLP-1 receptor agonists that we should be using because they all have proven benefits. So what are the standards of care that we all need to follow? And unfortunately, not everybody follows, and it's not bad to emphasize. I think it's important that glucose control, we individualize, of course, but in general, we aim to less than 7, around 7. And if you have comorbidities, you may go up to 7.5. LDL cholesterol lowering is very critical, preferably with statins, for sure less than 100 milligrams per DL. And if you have established cardiovascular disease, less than 70, ideally. Blood pressure lowering, you may individualize, you may want to go to 120/70, but at least you need to do for less than 130/80. That individualized diet and lifestyle intervention, basically to avoid weight gain, ideally to have weight loss. And if you're going to intervene with weight loss, you need to aim for having a weight loss of at least 5% of body weight, which has been shown to have significant benefits. And smoking cessation. Smoking in people with type 2 diabetes is totally unacceptable. So in this multifactorial intervention strategy to slow down, we also can do that to slow down the progression of chronic kidney disease. Early intervention with trying to individualize people with good control, ideally less than 7%, it can reduce the progression of chronic kidney disease. We do see much less people evolving to chronic kidney disease. I mean, best example is in type 1 diabetes, that a lot of them used to move on to have chronic kidney disease. We used to see a lot of patients in their dialysis. We see much less. We see more for type 2 diabetes, not because we're doing less, better control, is because the explosion of the high frequency of type 2 diabetes, but certainly glucose control can prevent the progression towards chronic kidney disease. Individualizing blood pressure, for sure, less than 130/80, can also reduce or slow down the progression of chronic kidney disease. In patients with diabetes and hypertension, RAS therapy with an ACE inhibitor and ARB is also highly recommended in anybody who has And even if they don't have patients who have hypertension as a preferred a blood pressure lowering agent. And clearly lipid lower recommended to reduce of cardiovascular events, although when you have established cardiovascular disease are less effective. So one of the issues that we have, and has been mentioned today, is the issue of treatment inertia. And I think that we can overcome treatment inertia with individualized therapies. We know this a study from the UK from 81,000 patients that KK Kamlesh Kunti reported several years ago. Look at this. In a country like the UK, where it's supposed to have an NHS, where there's not an issue of formulary of cost, you can see here that if you have one oral agent, and if your A1C is greater than 8%, it takes 1 year to add another agent. If you have two agents, if the A1C is greater than 7.5, 8%, take 6 to 7 years to add another agent. And if you have three agents, it takes 6 or 7 years, despite poor control of greater than 7.5 or 8%, to add insulin therapy. So clearly, patients with type 2 diabetes may be subject to increased glycemic burden and glucotoxicity for more than 7 years prior to intensification. This is unacceptable. And the issue here is that by delaying therapy, but the delaying, even for 1 year delaying in comparing people who have less than 7% A1C or greater than 7%, you can see that the chances of MI increased by 67%, chances of stroke increased by 51%, chances of heart failure increased by 64%, and chances of a MACE composite of MI, heart failure, or stroke increased by 62%. So what is what we think when we are actually treating people with type 2 diabetes? We actually estimate the expected glucose lowering, the chances of hypoglycemia, and how much glucose monitoring is going to need, what comorbidities you have there that may impact the treatment, the cost, the polypharmacy and adherence. I was mentioned how Alice Chen does the magic, going from 16 tablets to 8 tablets when she uses fixed ratio combination. And obviously the dosing and timing. Are you going to do better with that tablet that is given twice a day or once a day? And so I think that addressing these challenges to individualized therapy may help us overcome clinical inertia. So what is happening now, and what is trial evidence of MACE, heart failure, and chronic kidney disease benefit? I have this slide that Professor Alice Chen kindly shared with me. When you look at those studies that have been done in DPP-4s, you can show they are neutral, and we reported the Carolina and Carmelina trials. These are the trials on SGLT2 inhibitors, and these are the trials on GLP-1 receptor agonists. They're all the one from daily and weekly insulin, and even oral semaglutide. So we have really good data now. And I said this slide that Professor Chen showed you, we can see that in the GLP-1 receptor agonists and the SGLT2 inhibitors, you can see that both reduce MACE and both work on risk factors in people with high risk factors. But you can distinguish some. For instance, cardiovascular death reduction only was shown very strongly with empagliflozin and a little bit less with liraglutide. Canagliflozin with the study specifically designed for chronic kidney disease and credence show a slowing down of the progression. In dapagliflozin, in a specific study, showing a reduction of heart failure. And the same is true with empagliflozin that has a kidney study that is ongoing, and also the EMPEROR studies that are ongoing for heart failure. And because of this, you can see there that you can see because of these studies, there's all evidence-based recommendations are impacting the standards of care for atherosclerotic heart disease and heart failure. And can you stop 1 second? Por favor, hagan silencio. FA's recommendation that impacting the standards of care. This is for diabetes organizations. Those are the recommendations. Cardiology organizations, you can see the Canadian Cardiovascular Society, American College of Cardiology, ESC, European Society of Cardiology, have also taken into consideration and one session that Alison devoted to reconcile the treatment guidelines. And I'm going to try to summarize this because I don't think that there's any contradictions. I think that there are very very good consistency there. And I think that it's time for us to take it very seriously and follow through. For instance, this is the ADA-ESD recommendation that was updated in 2019. And here's what has been shown many times, and it's very clear that in appropriate high cardiovascular risk individuals with established type 2 diabetes, we need to seriously consider the use of GLP-1 receptor agonists or SGLT2 inhibitors, independent of baseline A1C or individualized A1C target. It is specifically to reduce and slow down the progression of the atherosclerotic cardiovascular disease and preventing heart failure or the progression of chronic kidney disease. For atherosclerotic cardiovascular disease, the consensus gives preferences to the GLP-1 receptor agonist to reduce MACE, where it's been very consistent and indicators of high risk. Actually, even in people with high cardiovascular risk, it's been demonstrated in the REWIND study with dulaglutide that the FDA gave the approval for the use of dulaglutide as primary prevention in people with high cardiovascular risk. In fact, there is also the highly suggestion that is probably true for SGLT2 inhibitors, because in the DECLARE study with dapagliflozin that had 59% of people with a high cardiovascular risk, they also show that no differences with the entire cohort. So it's highly suggestive that the same is true and applicable for SGLT2 inhibitors. Primary preference is in people who have evidence of reduced eGFR with the evidence of chronic kidney disease. Clearly, in the CREDENCE study, and all these studies have shown EMPA-REG outcomes. Canvas study is shown very consistently that it slows down the progression of the kidney disease. And clearly, also the data on heart failure is being very robust, very consistent. And clearly, those are the agents, SGLT2 inhibitors, the one that has to be given preferences in people with type 2 diabetes and indication of high risk of heart failure and reduced eGFR. The American Association of Clinical Endocrinology has also clearly has clear recommendation. This is the algorithm for control. If there's established cardiovascular disease or high cardiovascular risk, evidence of CKD3, which is a reduction of EGFR from 30 to less than 60, or evidence of heart failure with reduced ejection fraction. There is the use of GLP-1 receptor agonists or to inhibitors. Specifically for CKD and heart failure is an HCL recommendations of the ACE, American Association of Clinical Endocrinologists. They actually recommend initial combination dual therapy when you have somebody with recently diagnosed with type 2 diabetes, naive to therapy, with dual therapy if the A1C is greater than 7.5%. I would go even further. I would think that in my book, my own personal opinion is not validated in any of the guidelines, but in my recommendation that in people with type 2 diabetes, there is no reason not to start a combination therapy right from the beginning. It is okay to use metformin, but I think that the metformin and SGLT2 inhibitors should be seriously considered as a first initial therapy, regardless of the treatment, regardless of the A1C. This is the European Society of Cardiology. They came with this recommendation that produced a little bit of discussion because they were very clear. In type 2 diabetes, drug naive, you don't have to wait for metformin. You start an SGLT2 inhibitor and GLP-1 receptor agonist monotherapy if you have evidence of atherosclerotic cardiovascular disease and also high risk cardiovascular risk. Even though that we should consider this medication, and this is the recommendation that in presence of cardiovascular disease or high risk, the use of an SGLT2 inhibitor, G1 receptor agonist, and then subsequently you can see that you can add whatever other agent is necessary to control the A1C. Very important. They also went with rigorous recommendations, being in the class recommendation one of level of evidence A, and they gave the highest recommendation to SGLT2 inhibitors, empagliflozin, canagliflozin, dapagliflozin, recommended for lower risk of to lower the risk of heart failure or hospitalization in patients with type 2 diabetes. And I think that this is very important to consider the recommendation from the European Society that I think that we need to follow. They also have very important recommendations for people with type 2 diabetes and chronic kidney disease. And again, they gave the highest recommendation, level 1, and they gave a level of B because they are waiting for confirmation from the EMPA kidney study, and that is specifically directed for kidney disease, and the same thing for DAPA. But the canagliflozin clearly demonstrated, and there is no reason to think that the other ones are going to give us any surprise. So I feel very confident that in people who have an EGFR less than 90, we should be seriously considered strongly recommended the use of an SGLT2 inhibitor. The European Renal Association, in the European Dialysis and Treatment Association, also they have their own recommendations. And they also recommend the use of SGLT2 inhibitors with people who have evidence of reduce EGFR with chronic kidney disease, because they can give cardio and nephroprotection whenever they have reduced EGFR. Very strong, consistent recommendations in all the different societies in both sides of the Atlantic. So the question is, we talk about SGLT2s and GLP-1 receptors. So do DPP-4 inhibitors still fit in the treatment guidelines? And I think that we need to give a little bit of perspective and understand But our emphasis in is SGLT2 inhibitors and GLP-1 receptor agonists. But it doesn't cover the entire treatment. And yes, you've seen this, that we give a focus and preference for people who have high cardiovascular risk. But if you want to improve the glucose control and avoid hypoglycemia, if you want to avoid weight loss or when I consider cost, then we need to also think about other agents, especially when there's a need to when a need remains for additional glucose lowers remains above individualized targets. So yes, you can start an SGLT2 and a GLP-1 receptor agonist. So what I would actually point this thing, those non-GLP-1 treated patients. Of course, if you have somebody on a GLP-1 receptor agonist, there is, I'm sorry, they should say the GLP-1 receptor agonist treated patient. Then you have the DPP-4 inhibitors because of the issue that we discussed, the very little side effects profile, almost none, no hypoglycemia, with neutral cardiovascular safety. So here you can see that they are all over the place. Whenever you need additional therapy, whenever you need to lower the glucose and avoid the hypoglycemia and avoid the weight loss, and if you have somebody on metformin and SGLT2 and in a DPP-4 and maintain triple oral therapy is a perfectly appropriate option. Same thing is true when for the recommendation from ACE. You can see here that they are all over the place whenever you need an additional option. What is important is that in the recommendations of the ESC, European Society of Cardiologists, they actually looked at the DPP-4 inhibitors, and they actually established that the DPP-4 inhibitors, sitagliptin and linagliptin, having a neutral effect on the risk of hospitalization and be considered for diabetes treatment in patients with heart failure. Very important. If you have any evidence of people who have a risk of heart failure, you can use their sitagliptin, linagliptin. And if you have a drug like empagliflozin that reduces the risk of heart failure, and you need additional glucose lowering effect, well, the use of Empalina, as because we demonstrated in the Carmelina trial that it's absolutely no risk for people who with or without heart failure to increase heart failure. And the other aspect for linagliptin is that it can be used in the same Carmelina. We use the same 5 milligram dose all over the trial, specifically designed for people with chronic kidney disease. And if you want to use other DPP-4s, well, you need to measure the eGFR and you need to actually adjust the dose. You don't need to do that with the linagliptin, as we discuss it in almost every single session, because it's one dose, once daily, independent of the function, age, disease duration, background therapy, BMI, and specifically teaching. This is very in vitro, very strong. Has higher potency. That's just the dose based on the that's what a 5 milligram dose, where the others have higher dosages. All the DPP-4s reduce hypoglycemia. All the DPP-4s, except for linagliptin, have done cardiovascular outcome trials and show cardiovascular safety. Linagliptin did it twice, Caroline and Carmelina, as we reviewed in this session. They all have cardiovascular safety profile, except for linagliptin that did not do the cardiovascular trial, but presumably is safe. I'm going to be fair with I don't have the safety, but they did not do the proper trial. And then kidney safety profile, no question, linagliptin in Carmelina is the only one that has completely or totally proven safety. Always one dose once daily, only linagliptin, and has the advantage to be combined with empagliflozin. So to summarize, I think that, as mentioned, people with type 2 has to be a multifactorial, aggressive, intensive risk factor management. Statins, we need to use good blood glucose control because it is important that when you have type 2 diabetes with heart failure, chronic kidney disease, or atherosclerotic cardiovascular disease, we need to use this glucose-lowering therapy that's shown evidence-based of proven benefit. However, a need remains for additional glucose-lowering agents with proven glycemic efficacy and long-term cardiovascular and kidney safety profiles. And when that is the case, when you need additional therapy, linagliptin offers a simple way to manage patients with type 2 diabetes because this is always one dose, once daily for a broad range of patients, including chronic kidney disease, but just mentioned, who are not on GLP-1 receptor agonists and require further glucose lowering. And I thank you for your attention.
Thank you very much, Professor Rosenstock. We thank you for the wonderful presentation. Though we had a little bit of interruption in your voice, I think the internet connection was not that strong today. But we got the full picture from your slides and from what you've mentioned. I believe that we have now established the case that probably patients with type 2 diabetes are at high cardiorenal risk early, whether they have subclinical risk factors ongoing or whether they have established events. In any case, I guess that there is no reason whatsoever that we don't assess this risk early and intervene as early as possible with solutions. We know that most of the patients are polymedicated, and accordingly, the number of pills that they are taking every day may intervene with their adherence to therapy. And this adherence to therapy is critically important in management of type 2 diabetes patients if we are going to achieve the